so inspired by the work that everyone is doing. And I want to say congratulations to all of you for your selection as presenters today. The oral presentation, I know it's been feeling like these poster presentations are mini oral presentations. I actually really like that too, because they're little snacks of take-home messages that it's been really fun. And I was saying to the group earlier, I see so many synergies across the school, and that's been very inspiring to me also. I'm going to jump in and get us started. I want to say thank you to Erin McKay for her previous work to get us to this point, and obviously a huge thank you to Jody Wang, who's been organizing all of these presentations, putting them on the web and coordinating our Zooms and all that kind of stuff. So thanks for making my job so easy. I'm going to start right away with introducing Dr. Held and her abstract entitled Redistribution of Basic Medical Science Content During Undergraduate Medical Education Curricular Reform, an Expert-Derived List of Recommendations. Take it away, Dr. Held.
Thank you, Dr. Zimmer. All right. So like Dr. Zimmer said, my name is Natalie Held. I'm one of the former Department of Medicine Clinician Educator Fellows and a current Pulmonary and Critical Care Fellow who's pursuing a career in medical education. And I'm going to talk to you guys about a project that I've done over the past 2 years titled, this tongue twister, Redistribution of Basic Medical Science Content During Undergraduate Medical Education Curricular Reform. Start with a little bit of background on medical education reform in US history. So historically, undergraduate medical education has comprised of 2 years of basic medical science instruction in the classroom setting, followed by 2 years of clinical experiences. And more recently, this traditional 2+2 model has been felt to be structurally inflexible, not learner-centered, and one that may result in poor learner connections between formal knowledge and experiential learning. And so current calls for curricular reform now really emphasize these competency-based milestones and encourage deliberate integration of clinical experiences with formal learning. And with that, we've seen earlier clinical immersion, so earlier times when students are starting clerkships, and shorter dedicated classroom time for basic science instruction prior to these clerkships. But there's no clear consensus on how we accommodate this shortened classroom period. Educators really want to focus preclinical content and topics that allow students to have early clinical success. But variable strategies have been described in the literature with mixed results. And this was felt acutely by CU faculty. The curriculum reform, now the TREC curriculum, took a prior curriculum that had 19 months dedicated to basic medical science instruction and shortened that down to about 13 months. And so as CU and other institutions undergo this big curricular reform, we're left with somewhat of an unclear direction as to how we redistribute these basic medical science instructions. How do we best redistribute these topics such that we have students with early clinical success and a strong foundation in the basic medical sciences by the end of the 4 years? So the goal of my project was to create a list of expert-derived recommendations that guide how traditional preclinical instructional topics can be redistributed within reformed curricula. The study itself was a modified Delphi process, and we did that because it allows data extraction from the collective expertise of a group when there's not a ton of formal literature on the topic. The participants for the study were faculty educators from US institutions that had undergone reform within the past 5 years. And those institutions required a preclinical year that was now under 18 months, as well as a step 1 requirement that followed the clerkship year. And this, using a Delphi process, allowed for us to get expertise from these participants that relied on their experience in curricular reform. I'll now take a closer look at our methods. We started by recruiting about 10 participants to participate in our first survey or in our first interview round. We did this by looking into the recent literature for faculty who had recently published on similar curricular reform. We then performed one-on-one interviews with these participants to get an idea of how decisions were made on topic placement at their institutions. These interviews were then transcribed and thematically coded to produce a preliminary list of recommendations. We then recruited additional participants to increase our census goal using a snowball sampling procedure. And we sent our preliminary list of recommendations out as a Qualtrics survey to each of these participants. And participants were asked to rate each of the recommendations with regards to both their level of agreements, as well as their perceived importance for inclusion in a list of recommendations on a 5-point Likert scale. They were also given the opportunity to provide comments. Then myself and the other investigators met and reviewed the results from survey 1. We removed recommendations that less than 70% of the participants selected that they somewhat or strongly agreed, or less than 70% selected that they somewhat or strongly had perceived importance. And then additional modifications were made based on comments that were made. And then we sent this revised list of recommendations out as a second Qualtrics survey. And for this survey, the participants were asked only to rate each recommendation with regards to their level of agreement on a 5-point Likert scale. Participants selected that they strongly or somewhat agreed were included in our final list of recommendations. Here are the results. We'll start by just reviewing a flow diagram of the study participants and recommendations. We started with 9 interviews with participants from 9 unique US medical institutions. And from those interviews, which we transcribed and coded, we came up with 31 preliminary recommendations. We then sent those recommendations out in our first survey to 40 participants from 15 unique institutions and had a 42% response rate. Following that, we removed 3 of the recommendations, added 5, and revised 5 based on comments. We then sent out our second survey to 38 participants from the same 15 institutions with a 58% response rate. And at that point, all of the recommendations met our inclusion criteria, which was greater than 70% selecting that they somewhat or strongly agreed. And we ended up with 33 final recommendations. Here are the results. I'm not going to go through these in detail. There's not enough time. I have them posted as part of the slides on the AME website for those of you that are interested. And I thought for the remaining couple of minutes, I was just going to highlight a couple of them and describe some comments made by participants that led us to write that recommendation. So the recommendations are divided into 5 specific categories. And our first category, which includes 11 recommendations, talks about curricular reform decision makers. The first recommendation reads, the decision-making group should include members with diverse clinical and basic science backgrounds. And comments made by participants included things like, as we move from a horizontally integrated curriculum to a vertically integrated curriculum, we needed to have interactions between basic scientists and clinicians. Or we build each other up when we work together. And we took the basic scientists and the clinicians and said, you need to sit in a room and figure out what is core basic science. Another recommendation read, with a common goal in mind, the decision-making group should be prepared to let go of topics or approaches to teaching that have been used historically. And participants said things like, you have to let go of your territory. You want to fight for what you think is really important, but you need to be open to changing some things around or doing it a little different than you've done before. And I think that adds to the success of delivering a good curriculum. Or even though I've memorized it when I was a medical student, that's not a good reason to keep it. The next section covered curriculum strategies. And one of these recommendations was an explicit goal of the curriculum should be to develop students' critical thinking skills with a goal of producing self-directed lifelong learners. It's not possible to teach students everything they need to know. And participants said things like, we want both the assessment system and learning opportunities that students go through to be more authentic, and that they're actually helping really prepare them to the thinking and learning that they'll need to do. or we really wanted them to have a solid grounding in the foundational principles and to be able to apply those principles to problem solving and to patient care. The next 3 sections cover the specific periods within the curriculum, the preclinical, clerkship, and post-clerkship periods. And so one of those recommendations from the preclinical section was topics chosen for the preclinical phase should be something that all students need to know, rather than topics that will be pertinent for only some students pursuing training in specialized fields. And participants said things like, I think it comes down to trying to understand, as physicians, as clinicians, in our care of patients, how do we do a better job because we're understanding the fundamental sciences in the care of that patient. In the post-clerkship strategies, one of the recommendations was, after clerkships, basic science content should be taught within a clinical context and involve a deep dive into that topic. And participants said, after clerkships, they know enough of the clinical language that they can actually go back and spend some time thinking about the foundational science and then take it to the next step and push it further. Or students have a chance to really engage in something that they're passionate about. So what are the implications of this long list of recommendations? For me, there were a couple takeaways. First, that basic science instruction should be vertically integrated into all phases of the curriculum, preclinical, clerkship, and post-clerkship, to produce well-rounded clinicians with a foundation in basic medical science. And that we should be doing this with evidence-based strategies focused on active learning. Second, that topics in the preclinical phase really need to be these need-to-know concepts that ensure early clinical success in the clerkships, with an emphasis on development of critical thinking skills. And that some historically taught concepts may not have relevance in this new curriculum. And finally, that basic science needs to be taught within a clinical context. And so the next steps for this project, I'm hoping to publish and disseminate the results, because I'm hoping that these recommendations can be found helpful for other institutions that are undergoing similar curricular reform. And with that, I will close. I just want to do brief acknowledgements of my mentorship for this project, primarily Dr. Jennifer Adams, who is my mentor and role model within medical education, as well as Ty Laxbizer, Sheila Jimenez, and the 2020-2021 TSP cohort. Thank you.
Bravo. Thanks, Natalie, for sharing that. I wonder, I'm gonna go outside the box to that next level. One of the goals of this vertical integration throughout all of the phases is really to think about creating a culture of lifelong learning. And I want to think about your perspective from residency and fellowship about how does that go to the GME space in terms of creating lifelong learners? What have you learned from this that you might apply in that next level?
Definitely. I think one of the big takeaways from the qualitative portion of this was how important it is to integrate basic science in all levels of learning in UME and beyond. I think reflecting on my time as my time in GME is coming to an end, we do a lot of this in our research pursuits, but less so formally. There's not a ton of formal integration of basic medical science. And I think to really build on that foundational knowledge within, as medical students, we should be finding ways to incorporate this. And I think one of the quotes I really liked from this was the one I gave about how do we take better care of our patients because we understand the foundational medical science behind it. And I think we lose that a little bit as we move past medical school. And I would love to find a way, I don't know yet how, to better integrate this.
And the other question I think that I had, I don't know if others have things, please, feel free to type in the chat or unmute. We're a small enough group, is whether or not, most of the feedback was from clinicians about how to do this for our patients and to only teach things that they need to know to be doctors. And from the basic science faculty perspective, at least the local feedback has been, what about learning things for the sake of learning things? And what about this curiosity piece and fundamental science? And why are we not, who gets to be the voice of those folks who advocate for that? I don't know if any of that came out in your qualitative data.
It's hard. It's a hard thing to answer. We did include some basic science PhD background, non-MD backgrounds as part of this, who were part of curriculum reform at their institutions. And I think it was really important that basic scientists have a seat at the table during curriculum reform, because it's important to get that voice. I think we sometimes think, well, this isn't necessary for this specific clinical care, but it is important to become well-rounded clinicians and well-rounded doctors. And I think one direction I'd like to see this going in at some point is this fundamental question as we make these major changes in our curricula. What does it mean for physicians as a profession? What does it mean as we redistribute and sometimes truncate some of our basic science instruction? What are the outcomes of that? And I don't know that we know yet.
Yeah, great. Thank you for your insights and for this awesome work. Those Delphi research studies are really hard to do and require a lot of time. So congratulations, you made it seem so simple and easy, but I know that you did a ton of hard work there. So congratulations and thank you. I'm going to transition to our next abstract, which is being presented by Dr. Tyra Feinstad, and the topic is Better Together, a novel online physician group coaching program to reduce burnout in trainees, a randomized controlled trial. Thanks, Dr. Feinstad, for joining us.
Hi, thanks. I'm here with my coaching and research partner, Dr. Adrienne Mann, and she and I are going to kind of tag team these slides. Thanks so much for having us. We are so excited to tell you all about this life coach program that we created for residents. We came at this with a primary aim to decrease burnout in women residents. The reason we chose that is because burnout is a huge problem without a real clear solution. I have now had so many conversations with people who either want to blame the physician burnout problem on the institution or on the individual. And I think that just completely ignores the problem of the culture that we have been creating and propagating, and affects both the institution and the individuals. I think it starts early in training, maybe even before training. Certainly the toxic thought patterns kind of emerge in medical school, and then I feel like they really take root in residency. And so this is the population that we targeted. If you look at burnout data across residents, it's anywhere from 2 to 10 times as that women are more affected by burnout than people who identify as men. That's sort of true for most wellness indices if you look in this population. So that's the reason that we targeted women with an aim to sort of level that playing field. Professional coaching or life coaching is a solution that has been written about for physician burnout before. Most of the literature out there uses a non-physician life coach and in one-on-one coaching sessions. Dr. Mann and I are both intimately familiar since we have had life coaches turn things around for us pretty significantly. And I want to just briefly say that when we talk about coaching, we are not talking about teaching. The term coaching in medical education often gets thrown around and can mean many different things. A lot of the time it means really good teaching. The type of coaching that we are talking about is life coaching or professional coaching, in which we are looking at a trainee's thought patterns with a goal to help them succeed as defined by them. So we are not mentoring, we are not advising, and we are not teaching. We use a tool for metacognition to help trainees look at their own brains and basically help them identify areas where they might be getting in their own way. This includes things like perfectionism, which affects professionalism, but also imposter syndrome, low confidence, addiction to approval, all that type of thing. We created a 6-month program that Adrienne will tell you about on the next slide. But before we implemented it, we enrolled voluntary women residents here at CU. We got 12 specialties represented, and we stopped enrollment at 100. One extra one snuck in there, just based on what we thought we could how many we thought we could feasibly coach in a group setting. Because we had such enthusiasm for this study, we got 100 participants relatively quickly. We decided to study it in a randomized control trial. And we separated our voluntary enrollees into an intervention group and a control group. We surveyed everyone at the baseline. That's the data that you're looking at here. And this is in December of 2020. So mostly the top right of this screen, the very top right, is the 3 facets of the Maslow burnout inventory. That was our primary aim, and then followed by our secondary aims, NEF's self-compassion scale, the moral injury symptom scale, and the young imposter scale. You can basically just see they were not doing well. This is worse than some of the national data we had seen. Maybe it's because it's just women. Maybe it's because of COVID. Maybe it's because they volunteered into a coaching program and so sort of self-selected for people that needed it. Although other studies would have us believe that maybe the people that need it the most are not the ones that voluntarily enroll. But here's how they were doing right before our coaching program.
Thanks, Tara. So I'll tell you all about what our intervention was. So after being randomized to the intervention or the control group, we started the coaching of the control group in January of 2021. And the participants received a 6-month program where they had access to coaching in 3 different ways. So the first and most common, we think, way that folks were engaging with us for coaching was on twice weekly Zoom calls that we hosted at 7 p.m. on Tuesday and Thursday nights. It was either Tyra or I hosting a call. And on these calls, anywhere from 2 to 15 or 20 participants would come on and would raise their hands to come up in front of the group and be coached on something, anything that was going on in their life. Maybe they got bad feedback, on a MedHub eval. Maybe they were going through something with a family member that was a struggle. We literally coached on anything that anybody brought in. And this would be a dialogue between the coach and the participant for between 10 to 20 minutes on average, that would be observed by the rest of the group who was on the call. Those calls would then be stored on a shared drive. So folks who weren't able to join live could jump on the shared drive and watch them later. So everybody got to benefit even if they couldn't be there live. The second way to get coaching is through self-study modules that we develop. So there's a weekly short video that's about 10 minutes and accompanying worksheets that we prepared and delivered to the participants in a workbook that they can go through at their own pace. We're not tracking that. We don't, receive them back. We don't know how much time they're spending on that, but they can do as much or as little of that work as they want. And then the third way is an anonymous way to get coaching. And this is through our secure website where participants can submit written coaching on any topic. They write in a narrative about, hey, this is something that's going on for me, I want coaching on, and either Tyra or I respond back within 24 to 48 hours with coaching. And this gets published to the website that everybody can read. But as you can see here, there's no identification unless the participant wishes to disclose their name, but everybody can read it. So those are the 3 prongs of our coaching interventions. And here are the topics that we cover over the 6 months. In month 1, we teach them what we call the thought model. And this is a tool for based in cognitive behavioral therapy that I kind of call the SOAP note for the brain. So we teach the participants a method about thinking about their thinking. And this is the foundation of all the coaching we do. We help them apply that in month 2 to goals, values, and purpose. And then in months 3 through 6, we really dig into a lot of the things that Tyra was telling you about our ideas of who we are as physicians and as physician culture. We spend a lot of time in imposter syndrome, approval addiction, confidence in transitions, feedback in the growth mindset is really where a lot of the best coaching happens.
Okay, the money slide. We surveyed everybody after the 6 months. So this is, we delivered it between January and July of 2021. This was in July of 2021. And our intervention group is the blue line. And we found statistically significantly lower emotional exhaustion and overall burnout. Those 3 squares across the top are the 3 subsets of the Maslow burnout inventory. Once again, we also reached statistical significance in self-compassion improvement and had a lucky curative reduction in imposter syndrome just based on where that scale draws its line. The thing I want to especially point out is that we were very excited because we did a power calculation initially that showed we were very underpowered to find statistical significance based on the Maslow burnout index in a similar population of residents or med students. Our statistician told us we would need somewhere between 500 and 600 to move the MBI even 1 point. And we moved it 4 with just over 100. So we were very excited about this.
Yeah, and we are planning to scale it up. And so the next step for our program is to kind of demonstrate that it's feasible to take this and deliver it to more people with very little additional effort on our part. So as we kind of mentioned before, our first control group was 50 participants. Following that, we coached the control group. Sorry, we did the intervention group first, then the control group got coaching, and now we're in the third cohort, and we're coaching about 115 women trainees right now, and we've expanded to include fellows. And this has gone fantastic with 100% increase without Tyra or I really even changing the amount of effort we're giving to the program. In fact, it's less because we're not developing the new content. And we are planning now to expand to a multi-site study in the fall where we've already recruited, I think, about 20 institutions where we plan to involve at least 1,000 women GME trainees from across the country to deliver the same intervention and demonstrate feasibility and efficacy there as well.
So that's our program. We wanted to have some time for questions just because that was a lot, I know. Does anyone have any questions?
Thanks. One of the questions that I have, thanks to both of you, obviously tremendous results and way to move the needle in a really difficult time too, which is even more meaningful, I think, given how difficult the world has been. One of the questions I have is what you think institutionally we should be doing based on what you learned from this process.
We have a lot of thoughts about that. Tara and I both feel like this intervention that we built, this 6-month thing, is applicable to everybody. And we envision having it so that we could offer a 6-month program to faculty in the School of Medicine, to UME trainees, to GME trainees, and to have it be able to cross specialties. There's something that's really powerful about having participants who are fellows and residents in different fields, and it's really powerful. And so we would love to have the opportunity to build something within the institution that allows us to scale this to UME, GME, and faculty.
Yeah, we also think that an easy kind of maybe now low-hanging fruit for institutions so I said at the beginning that burnout is typically thought of as a either individual or institution problem. Meanwhile, you're ignoring the problem of the culture. One way to hold the institution accountable, but still offer some individual responsibility, is for institutions to offer a program like this for free to their students, faculty, staff. So then there's this huge sort of level of autonomy that the individual has. They can dive into the coaching as much or as little as they want or need, and it's offered to them by their institution. Life coaching otherwise is very expensive, especially physician life coaching. And so offering that as a resource is a pretty big step for an institution. We've started to sort of branch out into seeing what this would look like. Adrienne and I are both coaching a couple of departments here at the School of Medicine faculty right now. And so I think that's the way that the tides are going. But offering it to trainees as a primary care doctor, I cannot stress enough how awesome it would be to prevent these things that happen. I think like day one of med school, if you could learn how to name and process an emotion, that's just as important, if not more, than the Krebs cycle.
May ask Dr. Held to add that to her recommendations. So I, in the interest of time, I'm sure we probably should move on, but I just want to throw one little thing out there, which I know Mark Moss has done a lot of work around this, is that the people who are hurting even more than our colleagues as physicians and clinicians are our nursing partners, and really trying to see whether or not the healthcare system would prioritize that group of people, I think would be another place to advocate. All right, stay tuned for Lottie Derby joining us in just a month and a half. All right.
We are excited.
Yeah. All right. Thank you so much. Dr. K, I'm going to turn the microphone over to you as you get your slides up and say thank you for Game On, email facilitated case competition as a format for high value care education.
Hi, thanks everyone. My name's Hannah. I am one of the second year categorical pediatrics residents. I realize I didn't explicitly put my department here, but I guess you can see at the bottom. And My talk today is on an email facilitated case competition that we conducted or delivered last year to our residents as a model for delivering high value care education. Let's see. I have no financial conflicts of interest to disclose, and these are the other members of my team, Kim O'Hara, Mike Chu, and Barry Seltz, who we all work together on this curriculum. So a little bit of background for everybody. I'm sure that many of us know that high value care in medicine is a hot topic of discussion, as overdiagnosis and overtreatment contribute to high costs and potential harm and side effects to patients. And one strategy to reduce costs and to deliver more quality care is to train physicians to deliver high value care, meaning taking into account the quality and the safety of care that we in the experience of patients over the cost or downsides of those treatments. The ACGME mandates that residents have a cost awareness component into their care and in their education, but there's currently no standardized curricula in the pediatric space on how to deliver high value care education. A study from 2014 showed that about less than 20% of pediatric programs had a standardized curriculum. And so our objective was to implement and evaluate a longitudinal email facilitated high value care curriculum for pediatric residents, utilizing a case competition focused on cost-effective diagnostic evaluation. So in developing our curriculum, we adhered to current 6 steps of curricular development, meaning that we did a general needs assessment, kind of covered in the background there, a more targeted needs assessment, which I won't be going over here today, but surveys of residents and a high value care culture survey at our institution. And we were informed by the conceptual frameworks of social cognitive theory and communities of practice in creating this curriculum. So the design is it's email facilitated, and the primary reason for that initially was the COVID-19 pandemic and not being able to be really in person for as many resident education sessions as we had been previously. And we wanted people to be able to participate flexibly from different sites as well. So this is how our curriculum kind of flowed. So as a team, we wrote 5 different clinical cases that were delivered by email every other month for the curricular year of 2020 to 2021. These were different case vignettes that were either in the emergency department or in a clinic setting, where you have a patient scenario, set of vitals, and you, as a residency class, either the PGY1s, PGY2s, and PGY3 pluses were grouped together, and they would get together either on group chat or email to discuss the case, discuss what other history and diagnostic elements that they would like to request, and email our faculty facilitator requesting those. The faculty facilitator would then email them back with results of the diagnostic tests or answers to their history questions. And by the end of the week, so we would start on a Monday, by a Thursday, the teams who would each give their final diagnosis after all of the diagnostics that they requested. And at the end of the week, the entire residency program was emailed the final diagnosis, kind of the thought process of what would be the most cost-effective or high-value workup, and some learning pearls that were emailed at the end of the week. And they were scored based on their workup. The overall winning team at the end of the year, who had the highest score total, got an ice cream social at the end of the year. To evaluate this weekly, or I guess with each week that we sent out these cases, we surveyed participating residents after the case regarding their attitudes, practice changes, knowledge gained, and their thoughts on the email format. We also conducted 2 focus groups, one with 2 residents, another with 3 residents, for a total of 5 residents at the end of the academic year on their experience with the curriculum. And then using basic interpretative qualitative methodology, we went through the focus group transcripts as as a group, went through iteratively and analyzed the results and came up with a set of themes. So for our survey results, a mean of 28 residents participated in each case, and that's the percentages of classes here. And our survey response rate among participants is 36%. We sent 6 different questions. I just have 2 of them for you here on a 4-point scale from not at all to mildly, moderately, and very either effective or useful. And we found that about 80% of residents found that the case competition was very or moderately useful for their clinical practice, and that email was either very or moderately effective as a mode for facilitating this kind of curriculum. Now onto our themes from the focus group. So these are the 4 themes that emerged during our analysis, and I'll go through them one by one with some illustrative quotes. The first one is enhancement of high value care attitudes, behaviors, and awareness. So one resident said, this was a nice exercise in demonstrating that day-to-day work that we do as residents can be exercises in high value care. And the decisions we make, does this test actually change what we're going to do for the patient? And I'll say, as a resident myself, this comes out in conversations on rounds and in our morning report education time, not infrequently, just as a subjective point. Another resident said, but it's the application, then you're practicing that skill and more likely to use it. So people felt that after having this experience, high value care concepts were more at the front of their mind. Residents felt that the case competition element increased engagement. I feel it was helpful with buy-in. I think in general, I'm one of the least competitive humans, but I will say it fostered collaboration among our class. I think it was effective at getting people engaged. And there would be comments about, wanting to be a certain class, or they won last time, so I really want to win this time, that kind of thing. Another resident said, I love competition. It's fun to make it a game. There's some camaraderie there. The next quote next theme is active learning through cases and collaboration. I think it's some of the most efficacious email learning I've experienced. I think I learned more from that than morning reports and things like that, because if I participate in high value care, it is my own choice. So this curriculum was not required, as you can see by our participation level each week, which we can talk about, but more supplemental education. And those that participated then felt like, they were doing this for their own enrichment, and we got things out of it that way. I think it's been motivating for me to just become a better doctor and better clinician, and be inspired by each other and each other's commitment to doing right for the patient. This one really made me feel great after working hard on this curriculum, and seeing that, people were working together on these cases and pushing each other to ask, will this add value for the patient? Like, will this contribute, to more success for the patient, or are we just doing this because this is what we always do? I think that is really meaningful, and this quote meant a lot. Our final theme is that email is a mode of delivery for high value care resident education, just as a general theme. I will say overall, aside from these quotes, a lot of people liked the email and also did feel like they missed in person, like kind of this torn feeling, especially our PGY3 who is in the focus group who had experienced a similar curriculum in an in-person format. It was interesting to see that she was kind of weighing the pros and cons of that. One resident said, when we're doing cases virtually and just over a more prolonged period, everyone has the opportunity to provide input that might not occur in an in-person format with such a large group. And another said, I think it gave us more time to percolate and to think. So it was interesting in this perceived thought of like, okay, the pressure's not on. I'm not sitting in a classroom over lunch and we have 5 minutes to come up with an answer. Like, I can read this email sleep on it, get to it the next day, talk about it with the class. I speculate that this may also contribute to a lower participation rate, as people may see the email, think about it, think they have some time to respond, and then Thursday comes around. So it was a yes and for both of those things. So our conclusions are, in longitudinal email facilitated case competition may be an effective strategy to improve resident cost awareness and awareness of high value care concepts. Gamification definitely increased resident engagement, and the email format allowed people to participate from multiple sites. I know our program's not the only one that has residents at multiple sites all over Aurora and Denver. And getting them together over the lunch hour for education is not always feasible. And further work is needed to incorporate other high value care principles, such as patient and family experience, into the curriculum. One of our residents pointed out that one of the approaches we used a lot is the stepwise approach of ordering one set of labs first that are more high yield, and then getting to the more lower yield, more specific or more expensive tests later. But if this is done on an outpatient basis, how would this affect family experience of having to come back to the lab or to the clinic? So thinking about those pieces is the next step for us as well in this curriculum. We're hoping to, we took a pause on this curriculum this year to evaluate, hoping to re-up it again for next year. Limitations are that we only perform this at one site here at CU over one clinical year, just with the pediatrics residents. We only had a few focus group participants, and there was variable class and resident participation. The PGY2 class had a little bit lower participation. We also have a heavier call schedule that year. So were there things like burnout and schedule that contributed, and that's possible. So yeah, our next steps are delivering this curriculum next year and considering a hybrid model, maybe having our final case of the year being in person, and integrating those concepts of family and patient experience into our cases. Thank you all so much. It was an honor to get to talk about this with so many wonderful people here today. So happy to answer questions.
Thanks, Dr. K. I'm going to start by saying, you said it felt good, some of those comments. You should feel great to design a curriculum that your peers adopt so well and that impacts them in such a positive way. You should feel really great and proud about it. There's so many layers of education in here, from just like the gamification piece, which I think a lot of people are thinking, how could I also do gamification in other areas or concepts? And so maybe you've thought about where else in the curriculum you'd like to do gamification. I don't know if that's the case.
You know what? I actually haven't, like other areas of resident education.
Yeah, like, I don't know, I'm an ID doctor, so like, or in the ICU or some other places where some of that gamification might be fun for people to be able to answer questions or do trivia or learn.
I think that would be great, especially if it's in the ICU setting, or I don't know, on your ID elective, if like one afternoon, you know, you have like more of like a little quiz of Jeopardy type thing. I definitely feel like as a resident, that's more fun than just being talked at. Kind of. So. I was an adult program director once before, and one of our residents did a gamification activity around EKGs that was really super popular, and I think, you know, usurped all the other learning that people were doing because it was so fun and popular. And I think resident-led activities are also, that's the other educational piece, is that coming from you, this is something that you know, kind of as a near peer, people are feeling more engaged in. And then the last thing I was thinking about is hard outcomes. So being able to measure outcomes on the floors. Did teams actually see decreases in their costs, or, you know, could you do a bill review or something like that at the end of the year? I think it's I think that could be a next awesome step for like our next phase of this curriculum, is looking more into that. We did conduct a high value care, oh my goodness, like a culture survey at the end of this that we're using for like another piece of another study. But that was something that we collected at the end of the year that we're working on analyzing. But I think looking at like some QI measures in the hospital would be great. Just, you know, we have, you know, just this focus group data, and then subjective experience as a resident that I feel like I hear high value care talked about a lot in like just little pieces in our education or in practice. You know, whether or not that contributes to like hard outcomes is hard to say, but
Yeah. Well, you could ask them to do some takeaways. You know, I remember learning how much it costs to have the oxygen turned on in the room versus just discontinuing the order and some of those interventions go there. And you have a comment in the chat box that says they would love to bring these games to the PICU. So next step.
Fun.
All right.
I'll be there next month.
Thank you again and congratulations.
Thank you so much.
Welcome, Dr. Liu. Thank you for joining us. And as you're sharing your abstract, I'll read it out here for you. Developing a trauma-informed training curriculum for internal medicine residents.
Okay, thank you for having me. Just give me 1 second to this on the presenter view. So go to the beginning here. Okay. Yeah, so thanks again. So my name is Gia Liu. I'm a hospitalist at Denver Health. This is my teaching scholars program that I've been working on for the last year and a half or so. And basically what we tried to do was to develop a trauma-informed care curriculum for the internal medicine residents. Just a little bit of background. So for me, I trained at a safety net hospital and I'm currently working at Denver Health, which is a safety net institution. So we see a lot of patients with a huge trauma background. But actually up until when I started looking into this about a year and a half, 2 years ago, I actually had not heard anything about trauma-informed care. So when I joined Denver Health, I became one of the faculty members that helps with the curriculum development in the health equity pathway, which is a pathway for our internal medicine residents or PGY 2s and 3s to elect to go into. And a couple Wednesdays throughout their year, we get to kind of teach and facilitate small group discussions on several health equity topics. So trauma-informed care was a topic that came up a couple years ago, and I'll go into that a little bit more in my background. But basically they needed someone to take over teaching trauma-informed care. So that's kind of how I got into the role. And actually, when I started reading a little bit more about trauma-informed care myself, I really came to the realization of how important of a framework it was in caring for very vulnerable populations on a day-to-day basis. So just to go through the background of what I'm going to be talking about, basically traumatic events in childhood are linked with an increased prevalence of many medical conditions, chronic medical conditions, and they can create conflict and reduce the physician's ability to deliver effective or optimal medical care to this population. A lack of formal training in providing care for patients with a history of trauma, coupled with a strong emotional reaction, can create conflict, and that can manifest and pose challenges to providing optimal medical care again for this population. And basically what I'm going to argue is that teaching internal medicine residents about the impact of prior trauma can help foster better communication skills between patients and providers and help avoid re-traumatization in vulnerable patients, which is an important outcome. So as I mentioned, a pilot study that was done in a prior year in the health equity pathway was done by a chief resident, Deepa, who I'll acknowledge later, but she basically helped put together a 3-hour training that was led by a psychologist, a local psychologist here, who delivered this training to the residents in the health equity pathway. And basically what Deepa found was that through this training, the residents, she did a pre-test and a post-test, and basically found that between the pre-test and the post-test, residents reported a significant change in both knowledge, attitudes, and skills revolving around trauma-informed care. So what Deepa did was she surveyed them just prior to the training, 1 week after the training, and 10 weeks after the training. And as you can see here in this graph, there was a significant difference between both the knowledge, attitudes, and skills that people reported. However, one other thing that you can kind of see is the numbers here are slightly limited, especially in the final, the 10-week post-survey. There were only 7 people who actually completed the survey. So basically what I tried to do was to take what Deepa did with her project and really try to put together a training myself that I could utilize in subsequent years, and use this to kind of develop this trauma-informed care curriculum that we can develop or deliver through the health equity pathway. So the goals of my project were, number 1, to develop a clinically relevant trauma-informed care training focused on reducing provider distress around caring for patients with a history of trauma. So, you know, being a physician and also delivering this content to internal medicine residents, I was hoping to really address what people would find relevant in their day-to-day interactions with patients. My second goal was to increase awareness of ways to reduce re-traumatization to hopefully provide for a better patient experience as well. And the third goal was to make a training that was adaptable and deliverable to all levels of GME from PGY 1 through 3. And one thing I neglected to mention was that Deepa's project was really only involved PGY 2 and 3, so higher level residents, but I was also including interns in my curriculum as well. And eventually, to kind of have this curriculum fleshed out, that I could adapt this to also involve medical students and graduate medical education, and also attendings as well, because again, I felt like trauma-informed care was adaptable and important for all levels of learners. So here, pictured here at the bottom, this is some images from the research that I had to do to kind of put together my curriculum. At the bottom here, this is pictured Vincent Felitti, who's the chief author behind the ACEs study, which comprised a lot of the background of my curriculum. And also a book that I read and felt was very helpful to kind of putting together my my teaching as well was The Body Keeps the Score by Bessel van der Kolk. So I think that these two references kind of made up the bulk of my presentation. Okay, so here I have listed the learning objectives of the curriculum that I delivered. The first was to understand ACEs as an important public health problem. The second was to recognize ways that ACEs might adversely affect a person's health and lead to adverse health outcomes in the future. The third was to develop a framework to recognize the impact of trauma in patients and to be sensitive to ways of avoiding re-traumatization in these patients. And the fourth was to raise awareness to think about ways to advocate for decreasing the prevalence and impact of ACEs. So the structure of the curriculum that I delivered, so basically the setting was through the health equity pathway. I was given essentially 2 half days, one where the entire intern class was, one in which, well, I guess the entire intern class was included in one of these half-day trainings. And then the second scenario was a half-day training that included both PGY2s and PGY3s that were that had elected to be in the health equity pathway. And basically what was involved in this trauma-informed care training was the first hour was devoted to a lecture that I gave myself that focused on things such as the ACEs study that I mentioned earlier that was done by Felitti. And also the other focus items were the chronic or heightened activation of the stress response that that was a result of having a lot of ACEs. And then followed by some discussion around how the brain gets remodeled, epigenetic changes that can kind of reshape people who have experienced a lot of trauma before in their past. This hour was followed by a 1-hour lecture from a clinical psychologist who had donated her time. So Sam Monson is a clinical psychologist at Denver Health who was involved in a study looking at the prevalence of ACEs at Denver Health clinics and how they translated into what patients wanted from their providers. So she shared a lot of her data around that study, and she also helped discuss how a provider's own history of trauma can manifest in their interactions with patients as well. And then this was followed by a 1-hour discussion with clinical case scenarios where we either talked about a resident's own, we provided a space for their resident to talk about their own experiences with patients with trauma history, or we also provided a sheet with multiple scenarios in which a lot of the health equity faculty members kind of talked about a case that they had that was challenging because of the patient had a significant trauma history. So again, the audience included most of the intern class who have not yet selected a pathway yet, and then PGY2 and PGY3 residents who had selected to be in the health equity pathway. So it was about 45 PGY1 medicine residents and about 25 or so the PGY2 and 3 residents. Okay, so the results, these are the compiled results of all of our evaluations from both the PGY1, 2, and 3 residents. And basically, after the training, we assessed their responses to questions such as number 1, which was, I feel that the session has helped me recognize signs and symptoms of trauma, even if my patient does not disclose them to me. Question 2 was that I feel that the session has reshaped my thinking about why patients who have experienced trauma may interact with the healthcare system in often less than optimal ways. Question 3 was, I feel that being able to recognize how my own experiences of trauma helps me understand why certain patient interactions might be more challenging. And question 4 was that I feel that the session has increased my awareness of issues that need to be addressed to improve the overall health of the population I care for. And for each of these questions, all of the residents either reported that they agree or strongly agree, with the exception of question 3. A couple more people reported that they were neutral, that they either did not have their own trauma history to play a role in this, or they did not recognize how their own trauma histories interacted with their patient encounters. Okay. So here are the open-ended responses to some of our evaluations. The one question that I asked was, how might you utilize one thing that you learned during, how might you utilize one thing that you learned during the session to change your practice? People said that they would reframe their conversations with their patients, that they would recognize signs of trauma even when a patient may not disclose them. They consider how their patient's life might be affected by trauma and acknowledging trauma when, even if it has a more subtle presentation. A lot of it involved around shared decision-making and making these patients a more active member of the treatment team. Okay, so the limitations to this study was that, for one, it was difficult to assess efficacy of this training in any kind of longitudinal fashion. For example, as I mentioned, the prior study done by Deepa, there were very few residents who actually completed post-survey several weeks after. A lot of things that we noted was that trauma-informed care, it's something that you don't actually really know the impact of learning this framework until afterwards, and you get a sense as to how this impacts you over our time in practice. So I think it'd be helpful to assess this in a more longitudinal fashion. And then the other thing is that that'd be really important to know is that how patients feel about whether or not this kind of education or this framework impacts their relationship with their provider. So we did not attempt to assess for this either. Okay, so future directions include expanding the training to target the entire internal medicine residency class early on in their training, expanding this training to different levels of learners, as I mentioned before, and multidisciplinary healthcare providers. So one thing we're working on is a nursing training as well, and then to work on developing ways to gauge effectiveness of this type. So these are the health equity pathway faculty that helped me in developing this project, and Sam Monson is the psychologist who helped deliver some of it. Ms. Paul.
Great. Thanks, Dr. Liu, for your presentation and your terrific work on this curriculum. One of the things I was immediately thinking about is the possibility of doing case-based scenarios later to see if they could apply what they had learned in this, and also even having, I'm just like melding several people's presentations earlier today, kind of melding the observer type opportunity where somebody could take turns being an observer in the conversation to say, did you apply the things that were learned in this curriculum? And then tying it to, I think Dr. Adams was a co-presenter on a presentation yesterday about trauma that medical students experience in seeing patients repeatedly going through difficult scenarios, and whether or not training the residents and even facilitators or preceptors will impact the way students are supported or how that's perceived. So there might be some synergistic collaborations there as well.
Yeah.
Really important topic, and I'm hearing more and more about trauma-informed care, but also trauma-informed education and what we're doing in those spaces. So probably, I loved seeing too, you didn't talk as much about it, but I saw it in your notes and your slides there that you included implicit bias in there too, which is, I think, where a lot of some of the trauma and life experiences intersect and then lead to disparate outcomes from a health disparities perspective too.
Yeah, absolutely. Thank you.
All right. Well, thanks again to everyone for participating. Thanks to all of you for your attention, and obviously to Jody again for organizing our sessions these last couple of days. I want to give a plug again for Friday. Dr. Zoe Cohen will be joining us at the noon hour to give the keynote address. She is the daughter of our beloved JJ Cohen, also an immunologist and also a presidential teaching award winner at her home institution of Arizona. So we'll hear from her on Friday. Thanks, everybody.